Pointer doesn't work, so I have to use but if I use this pointer, it is actually good because you're recording, the pointer will show up. So it's okay, doesn't matter. Okay, guys, how are you? Assalamu alaikum. Settle down, please. So let's just start. What is this?
That's the mic person.
Oh, okay. You guys are so high tech. You have one mic for me, one mic for Zoom, and look at this mic. This is like a micro version of the one that Adele uses. Like, look at this. I mean, if I pull it out to show you guys, honestly, I mean, it will disconnect. But look at how to show you guys. Do you know? Okay, you know. Okay, fine. So this is the second lecture, or rather, supposed to be the fourth lecture. But anyway, the second lecture of the hemodynamic disorders chapter that we are doing as part of the general pathology course, which is part of the POD block. And this is about shock. Okay. And I think you guys had two cases in PVL last week and this week on shock, right? So some of the concepts, inshallah, can we dim these lights, the front lights on? Okay. Yeah. So these are the learning objectives. Why is it not working? Okay. We will be discussing definition of shock, different pathophysiological types of shock, SIRS or systemic inflammatory response syndrome. It's an outdated concept, or rather a retired concept, but we will still discuss it because it covers some basic concepts. Then more importantly, the recent advances in shock has led to the development of SOFA, which is the sequential organ failure assessment, and quick SOFA, which is quick sequential organ failure assessment. Pathophysiology of septic shock, which is the most important at this stage. We'll be spending some time discussing the pathophysiology, and it's really important. Some of the concepts are actually tied in with the following lectures, but inshallah, we will cover it. Different stages of shock. Some of them you would still already be knowing. Morphological changes, and then clinical manifestations, and a very brief treatment overview, which is not really part of the block, but just to give you an idea, which we will be covering some parts of it in third year and mostly in final year. So what is shock? Okay. What about oxygen failure? That's not shock. Just perfusion failure, more or less, because unless there is blood, where will the oxygen come from? So shock or cardiovascular collapse is the final common pathway for a number of potentially lethal clinical events. All of these, we will be discussing them: hemorrhage, trauma, burns, MI, pulmonary embolism, and sepsis. It is a condition of profound hemodynamic and metabolic disturbances with failure of the circulatory system to maintain adequate blood supply, leading to end organ damage. And this is the key. The end organ damage is what leads to fatality and morbidity in patients who are suffering from different kinds of shock. And initially, when it's developed, you have already covered cellular injury with Dr. Ruban. This is reversible, but if it keeps on progressing and there is no treatment, it becomes irreversible. So that is the last stage, the irreversible stage. Now, there are several pathophysiological types. There are many ways to classify it. This is probably the simplest one that I can come up with. If you are preparing already for your assembly, you will find slightly different classification in the steps book. Okay, but mostly from the Robbins, they divided into cardiogenic shock. Most common cause is myocardial infarction. So heart fails as a pump. Heart is a pump. It fails as a pump. So that leads to cardiogenic shock. Hypovolemic shock, mostly secondary to blood loss, trauma, diarrhea, vomiting, anything that where the patient is losing a lot of fluids in a very short amount of time. Okay. Septic shock, any bacterial infection, and there are various definitions for it. Most of the lecture actually, about 70% of the lecture is about septic shock. Okay. So it starts from systemic inflammatory response syndrome to infection and its other manifestations. Anaphylactic shock is a type of type 1 hypersensitivity. Okay. Yes or no? Why would it be type 2? It is type 1. Anaphylaxis is type 1. Has these hypersensitivity reactions been covered with you guys with Dr. Garvin or not yet? Oh, sorry. I thought. What have you been doing? This is week 7, isn't it?
That's like 7 years.
And the neurogenic shock. These are the names. So in cardiogenic shock, examples include myocardial infarction and other causes, hypovolemic shock, hemorrhage, diarrhea, etc., septic shock, severe infection, anaphylactic shock, hypersensitivity, and neurogenic shock is usually secondary to spinal cord injury or brain damage. I will give you one more table. This is the one that I want you guys to remember. Please remember myocardial infarction as an index example of cardiogenic shock. And the pathophysiology is basically that the heart fills as a pump and it is unable to pump blood. And then the patient will go into hypotension, shock, and that can occur if no treatment is given. Hypovolemia, anything secondary to vomiting, diarrhea, burns, or trauma where a patient is losing huge amount of fluids in a very short amount of time is again going to lead to hypertension, and it can be fatal if volume replacement is not given. The basic pathophysiology is inadequate volume or blood. Septic shock is usually secondary to overwhelming bacterial infections, fungal infections, viral infections, can be any kind of infections. And basically, we will be discussing this in a lot of detail, but the basic pathophysiology includes activation of the complement system, release of the cytokines from macrophages and monocytes, activation of the clotting cascade, leading to disseminated intravascular coagulopathy, and end organ damage, multi-organ failure, and finally, death. No, not sudden death. It is gradual. There is no sudden death happens in cardiogenic and neurogenic shock. Neurogenic shock happens in the setting of an anesthetic accident, okay, or spinal cord injury. So if that happens, the patient is going to lose the tone, vascular tone, and there will be peripheral pooling of blood. The patient will collapse and they can die. Anaphylactic shock is usually an IgE-mediated hypersensitivity response. So I will give you an example. Usually, if somebody is allergic to something, like an allergen, any allergen, so once again, when the allergen comes into the body, it is going to activate through the eosinophils, IgE will be released, immunoglobulin E, and that is going to activate the mast cells, and the mast cells will release the histamine. You just recently covered it with Dr. Farr, acute inflammatory reaction, right? Now, when that happens, it is usually going to be mild, but in some cases, this is not mild. It is severe. It is known as type 1 hypersensitivity reaction, and it can be fatal as well. So anaphylaxis is usually happening to an allergen, same process, but more severe, more severe. Okay. So this is the 5 different kinds of shock, and their very brief pathophysiological subtypes. Go ahead.
So what is it? Like, where does the obstructive shock?
Yeah. So that is in the other classification. Yeah. So obstructive shock, the example of that is cardiac tamponade. So if there is collection of blood in the pericardial membranes around the heart, so it is going to cause obstruction to the blood flow outside, right? So heart cannot contract adequately. So that would be an example. So I said in the beginning, if you remember, that there are many other classifications. Since you have mentioned obstructive, these two, like the hypovolemic and the septic, are classified in distributive shock. So there are other different classifications, but we are following Robbins. And that is not a bad classification. So they have only 4 categories. Okay. So among them, like he mentioned, obstructive and distributive shock are mentioned. And that's okay. If they are more or less a lot of overlap, you just need to follow one. And the one that I try to follow, and the reason behind it is not just because it's from Robbins, but also because they are based. So if you know the name, your pathophysiology automatically comes to your mind. Like if it is sepsis, okay, it is going to be secondary to a bacterial infection, things like that. Hypovolemic, okay. Now, if you say distributive shock, then you have to connect. You will have another step, distributive leading to hypovolemic, secondary to this and this. So this is, I think, is far easier to remember, but that is also correct. Okay. Sepsis definitions have evolved and changed over time. Okay, the ones that I'm going to show you in the initial 3 slides, the next 3 slides, are the older versions. They are no longer in use. So we started with infection, and infection means invasion of a tissue with a microorganism, bacterial, viral, parasitic, anything. SIRS, or systemic inflammatory response syndrome, was an infection and any of these two things if they were present. So higher temperature, patient is febrile, heart rate is fast, respiratory rate is fast, WBC count is high, or in advanced cases, sometimes the WBC count falls. Also in some infections, the WBC count falls, so we call it leukopenia. But usually, if you remember that the normal WBC count is from 4 to 11,000, and if it is higher than 11,000, then that fulfills one of the criteria for SIRS. Sepsis was previously, not currently, previously defined as SIRS plus documented infection. So if there is infection plus any of the two signs that I showed you, infection plus SIRS, we called it sepsis. We called it. Remember, I'm using the word past tense, no longer used. Severe sepsis was sepsis and at least one of these signs, either reduced urinary output, areas of mottled skin, abrupt changes in mental status, low platelet count, acute lung injury. We will discuss this. Acute respiratory distress syndrome. If there were at least one of these signs were present, then we said that the patient had severe sepsis followed by septic shock. And the septic shock previously was diagnosed with hypotension that persists after resuscitation attempt. So even if you are giving IV fluids, the patient is still having a low blood pressure. Okay, so this was the different definitions that we were using previously. The current definition of sepsis is known as sepsis 3. Okay, the current definition is known as sepsis 3. And it is currently defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Okay, so this is life-threatening organ dysfunction caused by a dysregulated host response, human response to infection. Remember that SIRS is no longer used to define sepsis. It was discontinued in 2006, but many organizations, many hospitals, many institutes still use systemic inflammatory response syndrome to classify and use the same definitions for SIRS, sepsis, and severe sepsis and septic shock. But it was discontinued about 15 years ago. Okay, it may seem outdated knowledge, but the reason I'm covering is that the basic concepts are the same. So the evolving of the concepts happened, it started from here. This was the beginning. Currently, we call it sepsis 3, and we assess it not through SIRS, we assess it with something that we call SOFA, which is coming up on the next slide, inshallah. So when the patient has a bacterial infection and it is severe and it's spreading out in the body, and the bacteria rapidly multiplying, and they are causing infection and multi-organ failure. So sequential failure of vital organs happen. It does not happen like all the organs fail at the same time. It happens in a sequential way, one after the other, and it starts with lungs. So initially there is acute lung injury or acute respiratory distress syndrome, and the definitions for them are actually given beneath. If you want to look at the exact definition, you can see it. But basically, at this level, please just remember that they are unable to maintain their oxygen saturation. So they are diffuse pulmonary infiltrates in both acute lung injury and acute respiratory distress syndrome, and they are unable to maintain their oxygen saturation. There are formulas to calculate it, and I will show you one. After that, the heart will get affected and cardiovascular instability will develop, followed by deteriorating renal function, that the kidneys will start failing, kidney injury will happen, then the livers will start failing, then GI can start failing, paralytic ileus can happen, ischemic colitis, pancreatitis, GI hemorrhage may also occur. And finally, the nervous system will get affected and the patient can go into coma. So this is the way the sepsis leads to end organ failure or MOF, multi-organ failure. Okay. Now, how do we assess it? The recent advances have led to using this score, SOFA score or sequential organ failure score. And basically what it shows is that if we start with the respiratory system, we need to have a score of more than 2 points. Well, some of them are 0, some are 1, 2, 3, and 4. And as the score increases, the chances for fatality, the chances for increased morbidity, the chances of patient spending more time in the ICU, that increases. Okay, so that is why it has this importance. So once again, it starts with the respiratory system, And if they are unable to maintain their oxygen saturation till the time that they require mechanical ventilation, they require mechanical support for ventilation, then of course the score is increasing. If their platelet counts, the normal platelet count is from 150 to 400,000. So if their platelet count is normal, the score will be 0. But if they start falling down, then of course the score will start increasing. Why the platelets are falling? Because of the patient due to sepsis entering into DIC. What is DIC? We will discuss some part of it today and some part of it in the final lecture. Yeah, third or fourth lecture. Okay. So platelets will start following. And I will explain why platelets are following when we are discussing the pathophysiology of septic shock. Then the liver enzymes, the bilirubin, it starts increasing. If the bilirubin starts increasing and it crosses these cutoffs, then again the score will start increasing. If the heart is unable to maintain the mean arterial pressure, then of course the score will start increasing till the time we need to give them inotropic support. Have you guys done inotropic? Little bit of idea, things like yes. So dopamine. So if they need more and more dopamine support or epinephrine support, then of course the score will start increasing. There is something that is known as Glasgow Coma Scale. It's coming up on the next slide, and basically, which is really going to be covered with you guys in the neuroscience block, next block, inshallah, next semester. But basically, it is a score for assessing the patient consciousness level. So we call it Glasgow Coma Scale. So once again, if they have deterioration in their consciousness and a deteriorating score, it has a total score of up to 15. So as it goes down, the SOFA score will increase. And finally, if the creatinine is increasing and the urine output is decreasing, then again the scores will be high. Having said that, the concept that you need to remember is not to be, if I'm not going to give you the clinical scenario or some of these findings and ask you to calculate their score. Okay, what I want you to remember, and the concept that I'm trying to convey, is that in septic shock, when multi-organ failure develops, there is a sequence of events that happens, and that leads to death. Actually, it does not happen suddenly. There are sequences that happen. So liver will get, so the lungs will start affecting, and the heart will affect, then the kidney injury will happen, and then the liver will enzymes and the liver bilirubin will start increasing. The renal injury will happen, and finally the patient will go into coma, and then they can die. So just remember that there is a sequence of events that happens that is showing that the patient is deteriorating. This score, the SOFA score or the sequential organ failure score, is helpful in determining whether the patient need ICU support or not, and what stage he is, and what we can do to reverse it. So far, so good. Any questions? Now it has been overtaken by something that we call quick SOFA. Quick SOFA, because this had a lot of information, the last slide, and it is difficult to remember. But still many centers, when a patient comes in with a suspected sepsis, they have already printed all these things out, and they have to fill in the these scores to calculate the SOFA score. But the quick SOFA is much easier, because if patients are deemed positive for quick SOFA, if they have 2 of these 3, if their Glasgow Coma scale is less than 15, or the respiratory rate is more than 22, or the systolic blood pressure is less than 100, any 2 of these 3 would indicate that the patient needs urgent ICU care, urgent admission and care. High respiratory rate, low Glasgow Coma scale, and low blood pressure. So this is easy. This is, you should know. Quick SOFA. You can remember quickly. Okay, so please do remember. This is Glasgow Coma scale. I'm not going to go through it. It is just for the students who are wondering what Glasgow Coma scale is. It is basically assesses the consciousness level of a comatose patient. Okay, or even not even completely comatose, even if the patient is awake. So we can ask them certain questions and see if they are responding to our verbal commands. We ask them to open their eyes, and they open it, they have full score. If we ask them what time, where are you, what is your name, things like that, then they get a full score. And if we ask them to move their limbs and they obey the command, then they get the full score. And if they get the full score, their total score is 15. If they are unable to do this and it is goes down, 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 and anything below 3 is death, meant clinically death, anything less than. Okay. So in that case, we can calculate it, and if it is less than 15, then that indicates it is fulfilling one of the criteria for quick stroke. What are the other two? Low blood pressure and high respiratory. So the normal respiratory rate is from 12 to 16. 12 to 16, right? No? Well, if it is above 20, it is above 22, then it fulfills the second criteria for quick stroke. Okay, moving on. Now the current definition, the definition that I showed you previously was for sepsis. That is known as sepsis 3 definition. Okay, this is for septic shock. There two things are different. They're slightly different. Sepsis is bacterial infection plus organ damage which is happening. Septic shock is reserved for the patients with sepsis whose circulatory and metabolic dysfunction is such that their risk of death is significantly increased. So this is the current definition of septic shock. The previous third definition was sepsis plus persistently low blood pressure, despite resuscitation attempts with IV fluids. The current definition is this. This is for the subset of patients who have sepsis and their circulatory and metabolic dysfunction has become so much that their risk of death is significantly increased. That's why I covered that one. That one is much simpler to understand and remember. And they are identified as septic. They require vasopressor support, things like dopamine or epinephrine, to maintain a mean arterial pressure of 65 millimeters of mercury or more, and who have an elevated serum lactate concentration of more than 2 millimoles, despite adequate volume resuscitation. So if they fulfill this criteria, they are on inotropic support and their lactate levels are high, then these two criteria would indicate that the patient is now in septic shock. They have sepsis, plus now they are in septic shock. Okay. Okay, septic shock carries a very high mortality rate, about even in ICUs carries up almost up to 50%, multiple factors. It leads to about 200,000 deaths in USA, and incidence is rising. All the patients who are dying with corona worldwide still, we have forgotten all about corona as if the pandemic is over. It's not. There is still 6,000 to 7,000 deaths happening every day, and all of them invariably are because this leads to the changes that we are going to discuss in the pathophysiology, TIC, multi-organ failure, etc., and then the patient dies. Respiratory failure, and then the patient dies. Number of patients with life support, also immunocompromised patients, these are all contributing to increased number of deaths due to septic shock. And we need to remember that previously it was thought that only gram-negative bacteria were responsible for septic shock, but actually, recently, if you look at it, it is more common for the gram-positive bacteria to cause septic shock. Almost 30 to 50% of the cases are secondary to gram-positive bacteria. About 30% of the cases are secondary to gram-negative bacteria. And then the fungi and viruses comprises less numbers. But this table is before COVID. So this viruses would probably be now totally different in the last 1.5 years. Okay. Now, let's discuss the pathogenesis, and the next 3 and 4 slides are the most important. Okay, so far we were just discussing the definitions, really. Honestly, they were just definitions, but the important thing is to understand the pathogenesis. And the pathogenesis of septic shock, it results from the systemic release of these cytokines, tumor necrosis factor alpha, interleukin-1, interleukin-6, and platelet activating factor. Okay, how does that happen? Any idea? Has Garvin covered it with you guys? I think it has been covered in 2 places. First was in HLS blog by Peter. Okay, when he discussed PAMs and DAMs and toll receptor, and I don't know whether Dr. Garvin has covered.
Not yet.
Not yet. Okay.
Can I try?
Can I try?
Like, answer.
For the sake of time, I'm pretty sure you will be able to do it, but I need to finish it. Okay. So, but as long as you can recall this, it's fine. So what are toll-like receptors? Let's do it in short questions. So what are toll-like receptors? I will still ask him to do it, but let's do it in a shorter way. So what are toll-like receptors? These are Yeah. So they are basically present on cells like, so macrophages are monocytes. When they go into the tissues, we call them macrophages, right? So monocytes in blood, macrophages in tissue. They are the same cells. So in the liver, we call them the Kupffer cells. In the brain, we call them the microglia. In the pulmonary circulation, we call them the pulmonary alveolar macrophage, so on and so forth. So basically, these receptors, the toll-like receptor, they are up till now, if I remember correctly, there are 10 which have been identified, and also they are present on other cells, and they play a role in both acute and chronic inflammation. They recognize pathogen-associated molecular patterns. One example of a toll-like receptor is CD14, which is present on macrophages and recognizes lipopolysaccharide, which is released from gram-negative bacteria. So LPS is an example of PAMP, and CD14 is an example of. Very good. Okay. Now what happens now, this may seem to be a little bit complicated, but it is not at all. If you just follow me. So gram-positive bacteria or gram-negative bacteria, they release their contents, things like lipopolysaccharide, and they will come, so we call them the PAMPs, and they will come and interact with toll-like receptors, for example, CD14. And when they interact with it through a series of complex signaling pathway, they are going to lead to the activation of NF-kappa B. And when NF-kappa B in the macrophage, this cell, by the way, this big cell is a macrophage. So when NF-kappa B gets activated, that is like a switch for acute inflammatory processes. It is going to lead to the release of interleukin-1, 6, and tumor necrosis factor alpha. And these three are the main cytokines which are responsible for everything that is happening in cells. Okay, simple enough. At the same time, the macrophages are also going to release reactive oxygen species and nitrogen species, nitric oxide, etc., to kill the bacteria. But the things which are happening in sepsis, the multi-organ failure that is happening is due to the release of interleukin-1, 6, and tumor necrosis factor alpha. You want me to repeat it or you got it? Yes.
Does NF-kappa B also cause angiogenication?
What do you think? We have taken 7 lectures of immunology. He's saying yes. What are the antigen presenting cells? Isn't macrophage one of the antigen presenting cells? And if they are presenting the antigen, what will happen? Activation of the T cell. T cell. T helper cells, but B cells are the ones that will produce the antibody.
Yeah.
But you are taking it towards antigen antibodies and the bacterial killing. I'm taking you in a different direction. Look at the direction that I'm taking you. I'm taking you in this direction. Okay? Not in that direction. That is important for bacterial killing, overcoming the infection. That is the body's normal immune responses. We are not talking about the normal immune responses at all. What we're talking about is the side effect, actually, I should call it, or the sequelae of this bacterial infection and how and why the multi-organ damage is happening in the body. So the first step, of course, is these bacteria, gram-positive, gram-negative, coming in, releasing their membrane contents or their release their proteins, activating the toll-like receptor, leading to the activation of NF-kappa B, leading to the release of interleukin-1, interleukin-6, and tumor necrosis factor alpha. This is going to lead to a lot of things, and we will discuss each one of them in some detail. Okay, number one, these PAMs, they have released the toll-like receptor and interleukins. Now, these interleukins, they are going to lead to vasodilation and increased vascular permeability. Now, if that is happening, that is going to lead to the parasites causing the endothelial cells to move apart, and the fluid will go out. Okay, leading to edema that we discussed in the last lecture. At the same time, there is going to be an activation of the complement cascade. Complement cascade will get activated. Have you guys done the complement cascade? So it can get activated through 3 different mechanisms. But ultimately, it is a series of proteins in plasma from C1 to C9. And there are some which are opsonin, and there are some that causes the bacteria to be attracted to the sites, so on and so forth. But ultimately, what happens is that through a series of steps, it is going to lead to the formation of membrane attack complex. And the membrane attack complex is C5, 6, 7, no, C6, 7, 8, 9. Correct? Or not correct? Yeah, okay. So 5 to 9 is the membrane attack complex, right? So when the membrane attack complex gets activated, when the complement gets activated, it is going to cause direct endothelial injury. Okay. And when the direct endothelial injury happens, what will happen next is it is going to lead to the release of tissue factor from the endothelial cells. And when the tissue factor gets released, the clotting cascade will start. Okay. So if you remember, I don't expect you to remember, but just to recall, is there are three pathways: the extrinsic pathway, the intrinsic pathway, and the common path. Yes. So the extrinsic pathway started with the release of the tissue factor from the endothelial cells, and then ultimately through a series of steps, it is going to lead to the formation of clot. Right. Now, normally, in a normal person, if we had an injury, a cut, or we fall down and we have abrasion, the clotting cascade will only get activated at that site. The clotting cascade gets activated only at that site, at the site of injury. And once the clot forms, the clotting cascade will also stop. Okay, through other mechanisms, right? But over here, the bacteria are causing the release of interleukins, and which is activating the complement, and this complement is activating the clotting cascade in the entire body, leading to the formation of microclots all over the body, microthrombi or microclots all over the body, millions and billions of them. So that means it is more of a pro-coagulate state, pro-thrombotic state. Okay. Now, if the microthrombi are forming, it is going to lead to at least two things. Number one, it can cause organ damage in various organs wherever they are obstructing the microvessels, wherever the small capillaries are getting obstructed due to these microclots or microthrombi, though there the organ damage will happen. Yes or no?
Yes.
And what is making these microthrombi? The clotting factors plus the platelets. So platelets are aggregating together, and because the platelets are aggregating together, they are contributing to this. And the platelets are being consumed, and the clotting factors are being consumed at a rate that they cannot be replaced by the liver. All the clotting factors are made in the liver. Liver cannot keep up with the demand. Number one. Number two, platelets are made in the bone marrow, and the bone marrow cannot keep up with the demand. So for this reason, because the platelets get activated and they are being consumed for the formation of microthrombi, what will happen? The platelet count will go down. There is thrombocytopenia. Thrombocytopenia will happen, and this is what we call DIC. Look at the name. That's why I've always preferred to discuss DIC first and then, but anyway. So what is DIC? DIC stands for disseminated or diffuse. Disseminated means widespread. Intravascular means inside the vessel. Coagulopathy or coagulation. Remember the name. Disseminated means widespread, all over the body. It's not happening in one place. It is happening all over the body. Can you hear me at the back? Because I keep walking away from the mic. Sorry. And intravascular means it is happening in all the vessels, inside the vessels. So the clotting cascade gets activated. It starts forming microvascular thrombosis. That leads to tissue ischemia, and that leads to multi-organ failure. Is this clear? We have only discussed two mechanisms so far. We have time. So we have discussed two mechanisms so far. The first mechanism was release of cytokines, leading to vasodilation and increased vascular permeability, decreased perfusion, contributing to multi-organ failure. The second is activation of the complement cascade, leading to activation of the clotting cascade due to direct endothelial injury, leading to microvascular thrombosis, where the thrombi are going to cause tissue ischemia, and the platelets will get consumed, leading to low platelet count. So it's a mixed kind of picture. Mixed means there is microthrombi formation, there is thrombi happening, there is thrombosis happening all over the body. In addition, because the platelets and clotting factors are being consumed, the patient is also at risk of bleeding. So usually in DIC, and we will inshallah discuss it in the next lecture as well in detail, usually in DIC, the patient have a prothrombotic state, okay? But usually they end up bleeding from all the sides and dying from bleeding. So they start bleeding from all the sides, nose, eyes, ears, etc. The PAMs, or pathogen-associated molecular patterns, also activate factor 12, which is known as the Hegeman factor. And when they activate the Hegeman factor, which is the first factor in the intrinsic pathway, it is going to lead to the same cascade and same thing. So the clotting cascade gets activated through direct endothelial injury plus the activation of the Hageman factor. So far, so good. Okay. In addition to this, the tumor necrosis factor leads to systemic effects by causing fever. How is fever caused? Dr. Abrar has covered this. So tell me. So interleukin 1 is going to go where? Hypothalamus. And in the hypothalamus, the prostaglandin E2 is going to reset the temperature set point. That is going to lead to fever. At least that much that you know. In addition to this, other cytokines can also lead to immunosuppression. So this is in a nutshell the pathophysiology of septic shock and why septic shock leads to multi-organ failure. Any questions? Got it? Okay, just revise it and listen to the recording again if you are having. Also, always check for explanatory notes beneath my slides. Some of the slides will have it if you are finding, because some of the concepts I just touch and go through, but if you want more information, they will be there. But in the exam, because there is a huge amount of information in this block, okay? And it is not possible for you to remember each and everything, right? You're just starting in your journey, you're just in year 2. So some of the concepts I have touched in detail. So those that I've covered in detail, I expect you to remember. Some I have just touched briefly, not gone into the depth, okay? But some students, when they're studying, they want to understand more. So for them, I've put slightly longer notes, brief notes beneath the slides. Moving on. Now the dominant hemodynamic, thank you so much for coming at 8:45.
I'm sorry, I had an issue with my roommate.
Your roommate, what happened to him? He had diarrhea, dysentery, vomiting, shock, septic shock. Sit down, sit down. My mind is totally on shock. I'm not on your roommate at all. The dominant hemodynamic feature of severe sepsis or septic shock is peripheral vascular failure with vasodilation, maldistribution of regional blood flow. And then there is abnormalities in the microcirculation. We call them stop flow capillaries and no flow capillaries. Why? What is causing the obstruction of capillaries? Microthrombus. So if you understood the concept, the answer is microthrombus. So these capillaries get affected, and when these capillaries, they are in all the organs, liver, kidneys, lungs, everywhere. So when the microthrombi and brain, of course, they get affected, then there will be no flow of blood to that area, leading to infarctions, microinfarctions all over the body. Okay, and that's why the patient develops multi-organ failure. So kidneys are failing, brain is failing. That's why they develop coma. That's why they develop increased creatinine, decreased urinary output, and so on and so forth. Okay. Clinical manifestations include fever, shivering, nausea, vomiting, vasodilation, warm peripheries. This is in septic shock. We are discussing septic shock. Bounding pulse, hypotension. Other signs may include jaundice because of increased bilirubin, coma, bleeding due to coagulopathy. They can bleed from GI, they can bleed from the mouth, they can bleed from the nose, they can bleed from the anus, rectum. They can also develop rash and meningism if it is secondary to Streptococcus pneumoniae, or if the brain coverings, the meninges gets involved. And in some cases, they can also develop hypoglycemia. Why? Because the pancreas also gets involved, and they develop adrenal insufficiency as well. Now, what are the stages? What are the stages of shock? The first stage is known as, anybody? Compensated or non-progressive stage. So when this is happening, all of these things that we discussed are happening, the body's defense mechanisms are going to kick in. And what are those mechanisms? Give me a couple of examples. Very easy. Okay, keep going. Keep going. Keep going. Keep going.
Water retention.
Okay. So baroreceptor reflexes, release of epinephrine and norepinephrine, activation of renin-angiotensin axis, antidiuretic hormone release, and generalized sympathetic stimulation. All of this is going to contribute to retention of fluid and water and sodium and potassium inside the body. So that so there is a time where the body's defense mechanism, when they get activated, all of these ADH and angiotensin, this is reversible. This is reversible. But once that point reaches, if we have not done any intervention, if we have not given the patient broad spectrum antibiotics to fight the infection, if we have not given them resuscitation support with the type of support that they need, there is a huge list coming up on the last slide. things like dopamine, epinephrine, etc., oxygen support, mechanical ventilation support, whatever they need in the ICU setting, then this will become progressive. And that is going to be secondary to organ hypoperfusion. Finally, the last stage is the irreversible stage. And at this stage, no matter what we do, okay, we are physicians and doctors, we're not God, okay? So no matter what we do, once this stage happens and organ failure happens, the patient is going to die. Once the irreversible stage happens, then it is not going to help anything. Morphological changes include changes of hypoxic injury and microthrombi in all of these. So in kidneys, we can have acute tubular necrosis. In lungs, diffuse alveolar damage. And in skin, petechial hemorrhages. I showed you some pictures of petechial hemorrhages. They can happen secondary to sepsis, and they can happen, they are going to happen in sepsis secondary to DIC. Did you see DIC? Well done. Yes, you did. Well done. Sorry, who came late? Who just came late? Was it you? Where did he go? He went out? What happened? I just want to apologize. Where? Hi. I just want to apologize. I shouldn't have been so blunt. Okay, my apologies. Usually, I don't mind people coming in late, but if they come so late, it's even if they have a genuine reason. This lecture is being recorded. Just wait outside and come in later on. No, it's okay. It's okay. Just my apologies. I shouldn't be. I've been so blunt. Okay. Final slide. Management of shock. Not part of the blog. Not part of it. Don't worry about this. This may seems to be a lot busy, but this is what you will be covering in year 3 blogs and in the finalists, inshallah, when you are actually treating the patients and seeing the patient with shock. But it starts with ABC. ABC means airway, breathing, and circulation. Okay. So we need to make sure that they have a patent airway. We need to give them oxygen, support respiratory function. We may need to increase the monitor their respiratory rate, pulse oximetry for oxygen saturation, and anything else that may need. We need to do their blood gases. We call them arterial blood gases, ABGs. We need to give them, if they need, mechanical ventilation. We need to do all of these investigations, include culture, CBC, electrolytes, kidney, renal function, liver function, everything. And whatever is needed, that needs to be given. For circulation, we need to restore their cardiac output. And for that, they may require blood. They may require blood components, things like fresh frozen plasma and platelets, especially in DIC. They may require colloids and crystalloids. The difference between the two is the type that we are giving. So for example, Ringer's lactate, which is sodium chloride plus that would be an example of crystalloid. Colloid would be an albumin. Well done. Some people have done the PBL well. Some. Who is your facilitator? Oh. Yeah. They are probably only, you're recording this, 2 or 3 PBL facilitator who, mashallah, spends the full 2 hours. The students may not like it, but they benefit the most. And they have an added advantage that I've seen them, which is the MCQs that they get to do. They should take pictures and circulate in their PBL groups. Do you do that? No. So guys, these guys, they get 5 MCQs after each PBL. Yeah. So they get 5 PBL. Their group. Practice MCQs on the concept that is discussed. That is an added advantage. I don't know whether those MCQs will come in the exam, but they should take a picture and circulate in the WhatsApp group. Oh, see, are you in the same group?
I was.
And then you left it? Why? Oh, they changed it. Okay. Okay, so we need to monitor them, and we need to treat the complications. So if they are developing DIC, we need to give them FFP and platelets. They may require analgesia and any other thing that they may need. That's it. I think this is the last slide.